Hello, Uttam. Uttam, you will need to unmute yourself.
Yes, I have now.
Okay, good, good.
Can you hear me?
Just try and share your screen once again.
Yeah.
I'll keep my video off. Because
okay.
Suddenly, sometimes our son comes in.
Yeah, that's fine. Okay.
That's perfect. Just go forward. Great. Okay. And video, is it incorporated in the talk? How is it?
No, it need to be. I need to minimize. So we'll try that video as well.
Okay, just try the video for a second.
Yeah.
But learning isn't just about facts and figures.
Perfect.
Mind
Perfect.
also.
No problem. Okay. So if you can stop sharing, I've got 2 or 3 slides to introduce you, and
Yeah.
then I will stop sharing again.
So to stop sharing, yeah.
Yeah.
Okay.
Okay, great.
Is the light enough, or should I make it more? Okay, I'll switch on the lights.
It's fine, Uttam. It's perfect.
Okay, that's fine.
One of my colleagues, a young pediatric surgeon from Johannesburg, he may only be able to join us. He may be only able to listen because he is in operation theater. But with your permission, I will send your details to him, and then I'll send his details to you.
Sure.
He will be quite keen to be part of your training, maybe developing training modules, and even conducting some research together.
Okay, good.
Okay, so I will, sometime this evening, I'll send his details to you, and then I'll send your details to him.
Sure.
Yeah, we'll wait, say about maximum 5 minutes.
Yeah.
We'll just start, say about 2 minutes past 5.
Yeah, that's fine. I'll just sit quietly.
Yes, yes. Sit like a psychiatrist and not like a impatient surgeon hurrying the anesthetist to finish the block.
Yeah. What is the weather like over there?
See, it's a huge country, so the weather is quite different. Now here on the coast, it is, we are starting spring now. We are 1 month into spring. So weather is warmer than last month, which is good.
So what is the centigrade wise? Because the autumn is starting here and it is quite gloomy and getting darker now over here.
Our gloomy is much sunnier than your gloomy.
Okay.
Yes. So it is cloudy and cool, but we need much more rain. It's been very dry, even in our city for last 2 or 3 years.
Oh,
So we need real, like, torrential rain. Yeah.
so what is the rainy season usually?
Rainy season is summer on the coast here for us, between November and February. In Cape Town, it is during winter.
And the COVID situation, are you back to your clinical activities now?
Now, third wave has waned, but the rate of vaccination is still quite slow. I don't remember exactly what's the percentage, but it's less than 25% of the population is fully vaccinated. And there is such a huge backlog of routine planned operations, we can't even tell you. And shortage of anesthetists, shortage of nursing sisters. So the waiting list is now, we are booking for February, March now. So it's now gone to 6 months, which is really, it's not nice. It's not good at all. And it used to be about 6 weeks, 8 weeks was maximum.
Right.
And theater lists have been cut because of lack of anesthesia.
For even a tertiary care, it just used to be about 6 to 8 weeks.
It used to be, yes.
Oh,
Yes.
that was very good.
Yes. I know from UK, the waiting list is probably like 1 year, 1.5 years.
Yeah.
So even 6 months is really uncomfortable for us. That's too long. And anyway, as I say, in Africa, we don't sit and cry. We try and find out local solutions to local problems. Yeah, it's another minute or so, Uttam. Just
Yeah,
5
sure, no
past,
problem.
a couple of minutes past 5. People are joining in. So I hope we don't get a strong 4th and a 5th wave of COVID, because now the numbers are down. So let's hope they stay down.
We are getting third booster vaccination from next week.
I read that.
So have you had two doses? Yeah.
No, we health professionals, we were given single dose J&J.
Oh, okay.
Yes, so we received that in March. There is a talk about the booster doses, but I think that will only come early next year, once majority of the population has received their first quota of vaccines.
Just go and get a glass of water in case I need.
Sure. Okay, so I'll just wait for you to come back.
Yeah.
Hello, Nirav. Hi, Nirav.
Hi, Prof. Sorry, I'm stuck with an emergency. But
no, don't worry. No, don't worry. I've spoken to Uttam, and I will share his details with you and your details with him, so the two of you can directly communicate with each other.
Okay, thank you very much.
Okay.
Thank you very much. All
Good.
right.
Okay.
Thank you.
Okay. Uttam, can you hear me nicely?
Yes, I can.
Okay. Good afternoon, everyone. Welcome to our Zoom academic meeting of the Department of Pediatric Surgery in East London. We have an unusual guest today. We are going to have a talk on Spot On. And what it means is surgical performance optimization training by Dr. or Mr. Uttam Shiralkar, who is a practicing psychiatrist, but before that, he used to be a practicing ear, nose, and throat surgeon. and he practices in the Birmingham University Hospital in England. My association with Uttam goes as far back as August of 1978, when we joined the BJ Medical College, we call it college in India, medical school in Pune in Maharashtra in India. And Uttam told us recently that he joined medical school reluctantly. And he says that he was always a theater actor. In the initial part during undergrads, he used to be acting in the dramas. And when he started training, then he used to be in the operation theater. Uttam qualified with us, did ENT surgery. Then he went to the UK, did his fellowship, went back to Pune, practiced in the private sector, but then decided to do a fellowship in head and neck cancer, went to the States. And he had a major life-threatening car accident. And due to that, he had serious neck injuries, which made it difficult for him to continue surgical career. But he then changed his career and retrained as a psychiatrist. And currently he practices as a psychiatrist in England. And he teaches importance of psychological factors in surgeons or doctors' performance. Sorry. Uttam is a writer, researcher, and he is an invited speaker. He has conducted various workshops for surgeons in various countries. He has written books and chapters and scientific papers, and he has been invited to give talks in the international conferences on doctors' performance and well-being. So I welcome my very dear friend, Uttam Shiralkar, to share his knowledge and wisdom with us. Thank you, Uttam. I'll stop sharing and then you can share your screen.
Thank you very much, Milind. Thank you for your kind introduction and giving me this opportunity to share my experience and some ideas. Okay. Can you see the screen now?
Yes, very nicely. You can
Okay.
go ahead.
Right. Again, the title is spot on, and I will tell you the reason why I'm presenting this. As Milind said, I was a surgeon for 15 years. And while I was getting trained as a surgeon and was a practicing surgeon, I was mindful of my performance, and I did, or I tried to do everything, whatever each one of you might be doing or aiming to do to improve my performance, because as like every surgeon, I wanted to give my best to every patient that came to me. So I did everything, whatever everyone does, what every surgeon does. I'm operating as many cases as possible, gaining knowledge, attending master classes. Something worked, something didn't. The problem was I couldn't understand why some things didn't work and what I needed to do to achieve those aims that I wanted to. And also, I didn't understand why some things worked without me making an effort. But that carried on. And when I started working in psychiatry and read some psychology principles and techniques, it was a kind of eureka phenomenon for me, that I understood why some things didn't work and what I needed to do. With that realization, I have been sharing those tips to various surgeons across the specialties, across the seniorities, and they have found it useful. So I have been running this training for more than 10 years, and I have written these books on these specific subjects. So what I'm going to do today, in next few minutes, I'm going to share the recent understanding that we have, and hopefully with some of the advice or the tips make sort of create interest in your mind, and you would apply it in your practice. So let's start, because there's so much matter. I don't want to waste too much of a time in general sort of subjects. So let's start. Okay, so this is the first slide about the, let me sort of make it clear. I have borrowed this slide from an American surgeon. So if you see surgical performance, this is the kind of observation or experience people have about how we surgeons progress as far as the surgical skills is concerned. Right at the bottom, if you see the blue line, some of us drop out. They just realize after a few years of training that this is not their field, and very few percentage in this country, there is about 2 to 3%, or even maybe up to 5%, depending on specialty, trainees drop out. But those who continue their training and practicing, significant number of them remain competent, but at the middle sort of level. And some of them become expert. Now, this becoming expert starts during the training, but just becoming expert or good in training, it isn't cover your whole of the lifespan of a professional career. You need to do something about it. But there is, as you can see in this slide, there is a difference between expertise and competency. And we don't know usually, and we don't even bother to understand why some people become expert and why some remain competent in spite of working in the specialty for so long. Like, for example, in case of your pediatric surgery, some surgeons may be operating hernia or usual appendix for so many years. Still, sometimes their skill is not that great. So why does it happen? So this other slide can give you some idea why this happens. So the previous slide was a long sort of lifespans presentation. This is kind of a transverse section. This is kind of acute assessment that, as you can see in the level of performance, there is at the top of the arrow, there is expert performance, and rest they are either mediocre or average performance. As you can see here, there are two words written, cognitive and associative. So that makes the difference between the expert performance and the mediocre performance. So what is this business about cognitive or associative? Any skill goes through three specific stages, which includes surgical skill as well, and this includes any everyday skill. So the first stage is cognitive, second is associative, and third is autonomous. Now take, for example, tying a knot. When you learned initially tying a knot, how to tie a knot, you may have either observed it, or you may have seen somebody tying a knot, or nowadays you might have gone to a skill lab and were taught how to tie a knot. And then you started tying a knot, you tried say 15, 20, 30 times. That is the associative stage. Associative is a trial and error. And after tying it enough times, it became automatic. So most of you, I believe you are experienced that you are tying a knot in an autonomous stage. You don't have to think about tying on how to tie a knot. You just tie it automatically. And there are many other skills you don't have to think about performing it. So that is the cornerstone of becoming competent in a surgical skill. So this is very important of skill becoming autonomic. But there is a problem. The problem is when the skill becomes automatic, it doesn't improve. It stays as it is. So if you're tying a knot, if we say in 4 to 5 seconds, and it is of average quality or good quality, and you want to tie a best knot, and within 2 seconds, you have to go back to a cognitive stage again. So this cognitive, associative, automatic is a kind of, it's in a cycle. So if you want to improve skill, you need to put in cognitive efforts. Unless and until you put in cognitive efforts. So for like, if you want to improve tying a knot, you want to sort of obtain information, what you need to do to increase your speed, improve the quality. You need to make deliberate attempts for a few times, and then it becomes automatic. So this is how it works. And this is what I'm combining these two slides. In case of expert performance, they always put in more information and they improve. They keep on updating themselves And that's why they have become expert. So this cognitive and associative, if you see the arrested development, people become automatic immediately and they stop progressing. So that's why it is important to have this cognitive information. Now, you might be wondering what cognitive information you need to do. Now, I think considering the time, we may not be able to discuss everything cognitive, what cognitive information is needed, but I can give you some tips, some overview and some ideas. Now, after listening to this, you may be having two questions in mind. First, what exactly are these cognitive factors, cognitive input you need? And secondly, why? Currently, the surgery, especially very subspecialty like pediatric surgery, may have become very high tech. So you might be wondering, with this surgery becoming so much technologically demanding, why do we need these basic things like cognitive skills or cognitive input? I will give an explanation with some general examples in life. Now, you may remember how you learned to ride a bicycle. Maybe you are one of the parents or your elder sibling or someone elder in the family may have taken you on a bike, and you might have started riding within a couple of hours of help from this person. This 2 years of practice, and there you go. You have been riding bike for the rest of your life. How about learning to drive a car? It is relatively more formal affair. You need to have basic understanding of the car, how the clutch works, how the brake works, and you may have been taught either formally or some more, you need a lesson, you needed to take a license. So it is a more formal affair. What about if you want to some technical problem? Okay. What about if you learn to fly a plane as a professional pilot? It is far more serious affair. They check everything. They check your eyesight every 6 months, and there is a rigorous testing even when you have passed the test. So, and you need to know some basic principles of aviation. So the crux is, more complex the vehicle is, the more important these basic factors become. In a similar way, for surgery, our cognition, our thinking is such a fundamental thing that when you're operating a complex, very high-tech cases, high specialty, subspecialty like pediatric surgery, you need to understand some cognitive factors. Unfortunately, so far, we have been practicing learning the surgical skills in spite of being high-tech, like still riding a bike. So the time has come for us to pay attention to these cognitive factors, which will help you to improve your skill quicker and better. You might be thinking, don't we already do that? That while as many operative cases as possible, doesn't it incorporate the cognitive training? Yes, it does, but partially. Not everyone has got this understanding and idea about what exactly cognitive factors to know about, how to incorporate them in the training or in practice. There are nowadays a lot of simulators, very high-tech simulators, but still the research has shown that what you learn on simulator, not necessarily it gets translated or applicable into the operating theater. And there is one more catch. You know, this simulator industry, it is, of course, it's a commercial venture. They will make simulators for the procedures which are widely applicable. Many people are using it. And they won't be making software or simulators for very rare, complicated procedures. So actually, when you need the simulator for a particular case, you won't have it. You need to develop your own technique. And the training that I'm mentioning, I call it as a cognitive simulation, is useful for those cases as well. And you don't have to rely on anything. It is free of cost. You can use it anytime. So this is the training I'm talking about, the cognitive training. Now, the cognitive training is used in sports for many, many years. You can see this slide. They studied that mental practice and physical practice have equal results. And now they have shown that if you combine mental practice and physical practice, it gives better results. Before giving this specific information in relation to surgery, I'm going to show you one interesting video, about 7 minutes video, how they are using this mental training for athletes and how we can apply in surgery. Now, this when you are watching this video, just try to extrapolate all that what they're showing is how it applies to surgical skill. Okay, so here is the video.
But learning isn't just about facts and figures. Our mind also learns to do things. Think about driving a car or starting to walk as a child. And scientists have discovered another rather surprising way in which we master new skills. Rebecca Owen took up gymnastics when she was just 7 years old. Her life's ambition is to win an Olympic medal. She's practiced 5.5 hours a day, 6 days a week for 10 years. Her hard work and great talent have already won her a silver medal in the 2002 Commonwealth Games.
It's fantastic, yeah, the crowd are marvellous. I'd like to thank everybody for coming and watching, and they just help you get you motivated for the whole competition. It's great.
But to stand a chance of ever being selected for the Olympic team, Rebecca must learn a new, extremely difficult move. It's called a Ginga Salto. It involves flying off the high bar, performing a back somersault and a half twist before re-catching the bar.
Basically, you'll watch somebody do it first so you can get a general idea of what you're going to be doing and what you want it to look like. And then you'll start the progressions and you'll get like feedback from your coach, and they'll tell you what to do, what not to do, where you're going right and wrong.
Rebecca's coach is Colin Still.
It's the turn, release the bar, arms down. Watch
He
the bar.
begins by introducing her mind to the move.
Did you see the bar all the way through?
Yeah.
Hold the shape. When we teach a move to people like Rebecca, any gymnast, they must concentrate at the beginning. They know nothing, and we have to fill their mind with the idea of what we're trying to get across. And then we've got to get their body to follow their mind.
It's time for Rebecca to try the Ginga Salto for real.
So this one we'll take from a handstand.
The first time you do it on your own, you have to really concentrate on what you're doing. When you're stood there waiting to go, you do get a bit more nervous and you start to think about things that could go wrong.
Well, it was close, which is good. But you've got to see the bar and you've got to attack the bar with a hand so you actually grab the bar before the weight comes on the hands. Ready?
It's just not working. It's time for a more radical approach. It's a learning method called visualization. Rebecca won't have to move a muscle. Rather, she'll rehearse the entire sequence in her brain. Rebecca stands still and concentrates. She visualizes every stage of the somersault, the moment she releases the bar, the instant she twists her body, and the second she catches the bar. And she does this over and over again.
Visualization does help you when you're learning a new move. You can go through it in your brain before you actually have to do it yourself.
scientists have discovered there's a region of the brain that's activated when we imagine a body movement. Rebecca rehearses the move in her mind. She's creating pathways through her brain cells as if she were actually doing the somersault, all without moving a muscle. It means that when she does perform it for real, she should find it easier, because the pathways in her brain are already in place. Will it work? Rebecca has repeatedly visualized each tiny twist and turn of the somersault in her mind. But has she established strong enough pathways to make her body do it for real?
Right. Nice and positive.
Each time I do the move, it gets better because it becomes more automatic, so I can think about it less and think like more about what happened on the last one and try and correct it again on the next one.
Okay, so we'll stop it there. I believe you understood and appreciated the essence of this film. Although it is from sports, the principle applies for surgical skill learning and maintaining as well. I would like to point out at this stage that if you have watched Olympic or any other game, it is not just for the beginners, but nowadays this mental training or mental conditioning is used by elite athletes, all the tennis player, Olympic teams. So it is not just for beginners, it is for the elite athletes as well. So this was from the sports, but studies have been done in surgery as well. And this is the first randomized controlled trial. This was done in Germany. They had about 106 surgeons, and they were asked to perform laparoscopic cholecystectomy in a simulator. And there were three groups. One was given mental training. Other group was given practice on the simulator, and the third was control group. And if you see the results, you can see that the mental training and physical training on practicing on simulator perform equally well. And interestingly, mental group training performed better than physical training on some aspects. And you might be wondering how this is possible. But if we have time, I will give you the explanation why it happens. And in some cases, the point is, some cases, mental training is in fact better than performing, practicing physically. So based upon all this information you have heard so far, I have been conducting training by what is termed as cognitive simulation, that is kind of mental conditioning or mental practice. And it is creation or recreation of surgical procedure through multiple senses that resembles actually performing the procedure. Now, in the video, you saw them saying that it is a visualization, but in case of surgery, what has been shown that just visualization isn't enough. Visualization is important, but surgeons need something more than just visualization. And this is what needs some training and explaining. So this is what we have been doing. And recently we have published our results about how far this training actually helps surgeons in improving their performance in real life. So we had 21 senior surgical trainees. We divided them into two groups. One was control and other was intervention. The intervention group got training over the span of 4 months. So initially, both groups performed laparoscopic cholecystectomy, which was recorded, and then the intervention group was given training, and after 4 months, both groups performed, and both their performances were assessed by blind surgeons, 3 blind surgeons, and the results were compiled. So these were the results. The first one is intervention group performed less than half of the time that the control group. Usually it takes about 40-45 minutes for surgeons to perform the procedure. Intervention group second time performed in 20-25 minutes, so which is quite significant improvement. As far as the quality of performance is concerned, they use various 16 criteria, and again the intervention group performance was more than double than the control group, and these were the criteria. Their performance was objectively assessed by the consultants. And in these kind of techniques, it doesn't just enough that objective criteria are sufficient. Unless and until the surgeon themselves find it helpful, there is no point in that this training will be appreciated or practiced. And in this slide, you can see that all the surgeons, they were asked to rate their subjective experience of utilizing this cognitive simulation technique in their day-to-day practice, because it is not good enough for surgical skill improvement just on a simulator in a skill lab. Unless and until surgeons see the benefit in their regular operating theater, it is of no use. So that's how we ask them to rate their experience on the scale of 0 to 10, how good they found this training to be useful. On every account, they found it significantly better, especially about improving confidence and engagement and stress. As you can understand, nowadays, performing surgery has become very stressful for various reasons. So they have found significantly the stress become less. So if we see in this slide, I have combined both objective as well as subjective performance, and this is the result. The blue performance on these slides and the subjective performance, that makes this cognitive simulation technique very useful for surgeons across the career span. It is not just for trainees or trainers, because in various specialties nowadays, the robotic surgery is coming and the technology and techniques are changing every time. So even senior surgeons need to adapt or change their procedure to keep updated with that technique. So this is the kind of crux for the trainees. Once they apply these cognitive simulation or surgical performance optimization training, this is the thing that they will benefit, that they will have steeper learning curve than the conventional one. And thank you once again for listening to my presentation patiently, and thank again for Melin for giving me this opportunity. I would like to mention that we have just started online training. It is free of cost. Those who are interested can, I've asked Melin to share my email address, and those who want further information, I can provide the information online training for those who are interested. And I believe Nirav, I think Melin did mention to me about you. If you are interested, we can have a chat. But if anyone has got any burning questions, I'm happy to answer. I don't know whether I have exceeded the time limit, but I'm happy to answer and chat with anyone who has any queries or questions.
Uttam, thank you very much. No, you are perfectly in time. We're just about half an hour. So you are well within time. And thank you for sharing your thoughts and your knowledge, what you have accumulated and what you have proven scientifically. And I see Professor Alp Numanoglu. He could join a little bit later, but I think he at least watched 2/3 of your talk. And as you know, and most of the attendees know, Professor Numanoglu is the head of surgical divisions at Red Cross Children's Hospital and University of Cape Town in Cape Town. And he is deeply involved in the establishment of the surgical skills lab, the laparoscopic skills lab, and also he's involved in training. So,
Should I, should I stop sharing so that we can see each
yes,
other's,
please,
yeah?
please, yeah, please stop sharing. So I'm going to invite Professor Alp Numanoglu to make comments or ask any questions to Uttam. Alp?
Thank you very much, Milind, and thank you very much, Uttam. I mean, it's a fantastic presentation that we have watched, and also my previous interaction with you has been eye-opening for me. And I think you've once again demonstrated that we have a number of ways of training in surgery. It's coming from the Halstadian system where the professor used to teach the trainee, to skills training that takes place in a center, and what you have demonstrated is another beautiful facet of training that perhaps not many of us pay attention to, the due attention that it deserves, and perhaps it's something that individuals do but without knowing, but they do, and it's becoming in a very scientific format now with all the randomized control studies, and it's really been fantastic. So from my side, just thank you so much for sharing your experiences with us and opening this new route to many colleagues that I'm sure they will have interest in developing further.
Thank you.
Thank you very much.
I would like to add, I mean, just like Alp and Milind, the experts do acquire this, but they acquire these skills over the time. And not necessarily everybody, every trainee or every surgeon is able to pick up that expertise. And what the science has shown that you don't have to necessarily spend that much time in achieving expertise. There are other ways to shorten your expertise period as well, not just learning curve, but expertise as well. And the other point is that as the science has shown that after 50, there is a decline in cognitive and psychomotor skills, and it is good for the experts as well to keep their skills abreast and at a very high level by using these techniques. And again, you might be using it, it's just that you might be using it subconsciously or not knowingly and randomly, but if it is used explicitly, it works better.
Thank you for clarifying that. Learning surgical skills and maintaining your skills doesn't have to be a donkey's work. It can be made easier by these techniques which are available and which can easily be practiced. And I think it's a simile which I just realized. It is like that simile of meditation. So it is very close to meditation. If you visualize an operation and simulate it in your mind, you're almost meditating. And if you meditate properly, then obviously the rewards are better. So I think that is very good. And to be honest, whatever one can do to reduce stress, to reduce efforts in learning skills and maintaining skills, why not? Why keep on doing the donkey's work?
Perfect point, Milind. Again, what I consider, what I have experienced it after working, you have found out or you commented instinctively or intuitively.
Yes.
What I think that whenever people do this, it is a kind of mindfulness during the operation.
Correct.
And that's why it reduces stress. I mean, assisting, we want our assistant to be sort of engaged and engrossed, and they help us. This is what it does. Once they are taught or told about applying this cognitive simulation, they become so mindful that it is good for the main operating surgeon as well as for the trainee. So perfect analogy, perfect example that it is a mindfulness.
No, that's wonderful. I think most of us are aware of the concept of mindfulness. We talk about mindfulness in our department quite often because we try and detect stress at an early stage. We try to keep a check on each other and try and detect stress and we keep on reminding each other about being mindful. And obviously any surgeon always likes an assistant who is awake and present in the operation, not just mechanically retracting without being mentally involved. So I think all this will not only add to the enjoyment of the procedure. See, ours is not only a science, it's a science and an art. So we need to be able to enjoy day to day what we are doing. Even though the operation may be tedious, but it needs to be an enjoyable experience for not only the surgeon, but also for the assistant. And obviously that will improve the quality of operation and will impact on the recovery. So I think this all, they are like the pieces of the puzzle which fit together, and anything to improve quality of surgical care and improve the quality of our life, because with more and more technology, our life is getting complicated.
Yeah, it is.
So we need to try and make it simpler. And this is the technique to do it. So I see only one of our consultants is attending. Dr. Selo Machaya is our consultant in pediatric surgery. He is quite skilled, not only in open surgery, but also has very good laparoscopic surgical skills. And he is also academically oriented. He is actually 8 months into his PhD. So I'll ask Dr. Machaya to comment. Selo, please comment.
Thanks, Prof, and thanks, Tom. It's very, very interesting topic, which I've never really tried to dwell into, which I'm very keen on actually exploring further. And I always remember the analogy of monkey see, monkey do, but it sounds like now we have to change it to monkey see, monkey think, or visualize, then monkey do, because it kind of reinforces what the old saying was: the more you see a certain procedure, or the more you visualize the procedure, the more skilled you become, because you're more aware of the minor technicalities. That's why they always, in surgery, they always encourage you to see more and do more, because then you would have kind of tried to encounter as many variations as possible. But visualizing it, Shane, it's quite interesting, because then you can visualize that anomaly that you hardly ever see in reality, which might make your skill even improve. But it's a very, very interesting way of doing things and seeing things. And if this actually improves my own surgical skills, it would be quite beneficial, because if I improve, then I can impart my limited knowledge to my juniors, which then they'll improve much better, especially once they've grasped the concept better than I will. They'll definitely fly and actually be more beneficial to everyone. But it's very, very, very interesting topic. But thanks for informing us and introducing us to this.
Thank you. And again, very crucial point, because whenever I do this training for trainees, more than 50% say, why don't you teach this, or why don't you tell this to our trainers, because that is more important. And it is very crucial, because I feel that if I teach this to 10 trainees, okay, those 10 trainees would be benefited. But if I teach this to 10 trainers, 100 trainees will get benefited. So I would be more than happy to introduce this concept to trainers who has got, because as I said, it multiplies exponentially this information, and many more people will get benefited. So I'll be more than happy. As I said, whosoever has any active interest, anyone wants to take it forward, I'm more than happy to. I mean, with the technology now, it can be done online. It doesn't have to be face to face. We have got online programs. Everything can be done online. So I'm more than happy to be getting involved in this.
I think, Uttam, we will just use this talk of yours as the actual starting point of your project in South Africa. Because remember, you, I, and Alp have communicated with each other last year about it. but I think this is the next correct step forward.
Yeah.
And I'm very happy that Cello also is interested. I'll just try and see if Nirav can comment. Nirav is operating. So Nirav, are you able to comment? If not, don't worry.
I am. I found it very, very interesting. I'm very keen to pursue the conversation as well. I do apologize. I'm so sorry. I just had to come and help in theater. So
No, don't worry.
Yeah.
Yes.
Okay.
So,
Thank you very much.
so Nirav, what we will do is, I think you in Johannesburg, Cello here in East London, under guidance of Prof. Alp in Cape Town, I think you people facilitate Dr. Uttam Shiralkar to conduct online cognitive simulation training. You people set up whatever you need to do. And I think once you benefit, as Uttam says, our trainees will benefit, and everybody will benefit in return. So I will make sure I share Uttam's details. I've sent it to Nirav. I'll send it to Dr. Salomachaya also. And we know Prof. Alp is quite keen, and he will keep guiding us. And we should not just make it as an activity. I think we should really take it forward as a project, and we should really have formulated aims. It should also maybe a part of an ongoing research project or something like that. And so I think I have sort of given the baton in the hands of the young, active, energetic, skillful surgeons who will take it further. So, okay, Dr. Shinondo says, kindly share the info on the PAPSA group for us outside South Africa that are interested to. No problem, we will do that. What I will do is, with Dr. Uttam's permission, I will share his information, his contact details on the Pan-African Pediatric Surgical Association group. And people outside South Africa can directly communicate with Dr. Uttam, and then decide. Separate countries can have their training sessions, or COSEXA, which is College of East African Surgeon. Then there is West African College of Surgeons in the west of Africa. I'm sure Egyptian and Nigerian colleges and universities are very active. So I think Dr. Uttam will do whatever he physically can, because he's also has to work like a psychiatrist.
Okay, let me clarify. I will be relinquishing my psychiatry, and full time I'm going to be in this surgical performance coaching. So
really?
I would be more than happy. Yeah, I'm going to, because I think whatever active life is, professional life is remaining, I want to devote it 100% to this activity, because there is too much to do and too little time. So I'm more than happy.
That's absolutely wonderful news. This was a secret not known to me also. And for the time being, we will continue it as an online activity. But I think next year, your visit to South Africa is long overdue. And we have to plan it properly. Prof. Alp will facilitate, and there has to be some face-to-face course or something like that.
Sure.
And obviously you have to visit us in East London.
Sure. And just to add, in addition to this operative skill, I'm going to start another activity about decision making, because that is another crucial aspect of surgeons.
Absolutely.
How to make decisions. So that also I will share it with you, the training about decision making and all. But that apart, this operative skill is very much everybody's heart. So we'll start with that.
Yes. So Uttam, before I ask for your final comments, I just want to go back to Prof. Alp and maybe just give his final comments. Alp?
Thanks very much, Milind. I was just smiling when Uttam said there's so much to do in too little time, and I cannot agree more. There's too little time, and I think as one also goes through the different stages of surgery, one identifies and solidifies the areas that one really wants to spend time. And I'm very much in full agreement with him, and we look forward to having you across in Africa.
Sure.
And sharing your experiences with colleagues as well. And thanks very much for a wonderful talk. And thanks, Milan,
We'll
for
be in touch
organizing.
and we'll
this as
start.
well.
This would be just an occasion for us to start the active sort of ground for this activity.
I think it is very important to Uttam. And during this pandemic, since we started our department's weekly academic meeting on Zoom platform, we have almost breached the distance within months. So we are sitting in this small corner on the southeast coast of Africa. You are sitting there in Birmingham, but our meetings are being attended by colleagues from not only from South Africa, but also from East Africa, West Africa, and colleagues in the rest of the world. But in Africa, we are not like Brexit. We work together and we work as a cohesive group. So I think this really, it's an exciting concept for me, and I can actually see it coming into reality. And with you there, Selo and Nirav, young pediatric surgeons, with Alp, a senior person taking interest, I think this can only make our lives better and give us much more enjoyment in what we do. And it will ultimately benefit hundreds of trainees and like thousands of patients. So Uttam, just final comments from you, please. It was excellent having your talk. And just thank you again, and good to see you. So please, your final comments.
Okay. As I say, I mean, this is sometimes I feel a kind of loner and lonely activity, but when I get support and acknowledgement and appreciation from people like you, it is a kind of, it recharges the battery. Because as you know, for any new activity, there are a lot of hurdles, a lot of difficulties, not necessarily that we get responses that we expect, but these are the kind of things that charges my battery. So thank you very much, and hope to make this into an active progress and process for surgeons in South Africa and continent.
Thank you, Uttam. I will facilitate that with pleasure, and great to see you again. We will chat again personally.
Yeah, sure.
Thank you. All the best, and regards to family.
Just one suggestion: whosoever is technologically savvy in your group, if anyone can, if anyone want to make a WhatsApp group of this, like spot on for South Africa or Africa, I'm more than happy to be part of it.
I think I will request Nirav to organize that.
Yeah,
he is in Johannesburg, and I'm sure he will agree.
Yeah.
So
you need young mind with technologically savvy people.
Yes.
Not like us.
Okay, Uttam. Thank you very much. All the best. Okay.
All of you for listening to me patiently. Thank you very much.
Thank you. And for all the rest of the attendees, next week's meeting will be open to the staff of our department. In 2 weeks' time, we will have an interesting talk by Dr. Andrew Grieve, who is a consultant pediatric surgeon at Nelson Mandela Children's Hospital in Johannesburg, affiliated to Wits University. And he's going to talk about laparoscopic repair of inguinal hernia in children. So greetings to everybody. Good afternoon, good evening, good morning, wherever you are. And we will see you in 2 weeks' time. Bye, Uttam.
Bye, Milind. Bye. Bye, everyone.